in the remaining time, let's talk about something close to my heart, which is the management of local regional therapy. So let me turn to Michael. None of us are surgeons, but I think we all have to discuss with patients potential management of resectable disease. So how do you talk to patients about whether you could have a surgeon resect their tumor? I mean, how do you decide what's resectable and what's not?
It's a really common question when someone gets a diagnosis of melanoma, stage 3 melanoma, for example, involving a lymph node, or in some situations, what's called a oligometastatic stage 4, maybe one lung lesion or one area on the skin and a lymph node or something. And a lot of patients say, well, what about just removing the tumor? Can you just operate and get this tumor out of me? I don't want it in there anymore. And yes, you could talk about all the drugs that we've been discussing here today, but I don't want to go on any of these. I don't want infusions. I don't want pills. I just want surgery to remove all this. And so how do we think about that now in the current era? I think the complications of the conversation are getting more and more complex because we have now some very effective systemic treatment. And the real question is, what is the role of surgery in some of these situations? The standard of care for patients that present with stage 3 melanoma, especially those that clinically present with stage 3 melanoma, like a lymph node in an armpit, for example, is to surgically remove it and then consider that patient for adjuvant treatment. So while we are talking about some different clinical approaches that we may want to handle for that patient, I think we should keep in mind the standard approach for stage 3 resectable melanoma is surgery and then consideration for adjuvant treatments. However, we are seeing a change in some neoadjuvant clinical trials that are emerging at this moment, where we are treating some of these patients with resectable stage 3 melanoma with neoadjuvant approaches, either BRAF and MEK inhibitors as a neoadjuvant strategy, or single-agent PD-1 or combinations of ipilimumab and PD-1 prior to surgical resection. That is intended to try to make the surgery an easier surgery, to shrink the tumor and make it more resectable. And it's also intended to treat the micrometastatic disease, which invariably would unfortunately lead to recurrence down the line if we were only to pursue surgery alone. We have a lot of questions about what the role of neoadjuvant systemic treatment will ultimately be in local regional management. We have a lot of ongoing questions about what the role of adjuvant treatments will be after surgical resection. And we're hearing at ESMO this year about a lot of new updates in all of these areas, and it's going to be an ongoing complicated conversation.
Yeah, I guess there were a couple of neoadjuvant abstracts. One was by Alex Menzies from Australia, and there was another one from, I think, a German group, wasn't it, where they talked about Ipi-Nivo adjuvant therapy. So, I mean, you have both Ipi-Nivo and Dab-Trem.
That's Amsterdam.
They're from Amsterdam.
Netherlands.
So, the Netherlands. So, but Caroline, I mean, this is all really recent, but what did they see?
Well, it's very encouraging in the sense that very often you have a complete response that is seen pathologically. The real question is, what is it going to become in following the patients? Because we don't know how long to treat afterwards. So these patients with big, palpable stage 3 disease, in fact, the reality is that we think that they might be in reality stage 4. So we are in a situation of a very small burden disease of stage 4. So how long to treat? This is the real question. But it's interesting, and of course we have to encourage this kind of a trial, which will give us a lot of information concerning the translational research. I would like to make this point at this moment because, as we all say, we have to work in a very close collaboration with our surgeons, our radiotherapists, and for example, we have a good team of interventionist radiologists who help us to do the biopsy where it's not so easy, or the injection of the drug when it is not so easy for us, meaning that with all of the new drug that we have, not only our job is changing and our paradigm is changing, but the one of all the colleagues who are surrounding us and our patients. And now you don't have, in my hospital, I will never have a surgeon telling me, as it could happen before, I'm not going to do surgery for your patient, it's a metastatic melanoma. I'm not going to lose my time to do that, or to do several sessions of radiotherapy. It changes the whole face of the medicine, these new drugs.